So as a brief self-intro, I'm Jeff Chiang. I'm faculty here at UCLA in neurosurgery and computational medicine. A lot of the work that I engage in is more applied in the clinical health setting. So recently we've been building a lot of risk stratification models for decision supports. And really we're interested in models that can be deployed into the clinic and how and kind of the challenges that arise when doing that. And today, I know we titled the talk towards foundation models for electronic health records. That's pretty ambitious. Maybe I'll kind of caveat this. We'll be talking about foundation models for electronic health record-based decision supports. And so I'll be talking a little bit, I'll give an intro to these kind of foundation model approaches for EHR and talk about one approach that we've been trying out to leverage large language models to represent the EHR. So I wanted to back up. We've been talking about the EHR a lot this week and just kind of slow down a little bit and introduce electronic health records, which, as we all know, capture the timeline of clinical and administrative events in a patient's medical history. So this includes, fields we might be familiar with, like what kind of medications patients got, vital signs, laboratory values, diagnoses. These also have, information like timestamps for when certain procedures were ordered or other things like that. So putting all of these together, I'm hoping that this is visible. Putting all of these together with electronic health records, you can kind of get a more holistic view of a patient's health history compared to, say, the pre-EHR era. You can look at a patient's entire timeline. You can maybe they had a series of common symptoms before developing some chronic condition or something like this. I'm preaching to the choir here, but the electronic health, why are we talking about electronic health records? Why is this blowing up now? Really, 20 years ago, there was a call to go paperless for these things. And it was, interestingly, in this article written in 2016, there was a claim that it was projected that EHR adoption might reach maximum market share in 2024 in the small practice setting. And we can see this as of 2021. Sorry, these slides are a little bit old. Nearly 9 in 10 US-based physician offices adopted these kind of electronic health record systems, which really sets the stage for us to be able to develop these kind of more general, we can call them foundational models for EHR. So again, I know I'm presenting to the machine learning and health group, but since we're at CGSI, I do want to mention that EHRs can be used for more than extracting phenotypes. We saw some amazing work from Lisa on finding ways to kind of represent a lot of the information that's captured within diagnostic codes. But we can also use EHR archives to generate insights. For example, if clinicians see a pattern of symptoms or something like that, we can go back into the retrospective data and do a quick check and do some more data-driven inferences. We can develop risk stratification or diagnostic models. Maybe we can move towards decision support or treatment recommendations. We can also in the world of, if you want to take the idea of generative AI, we might be able to move towards forecasting and generation models, which might be able to say, like, forecast what's going to happen to a patient in the future. I'll be focusing on risk stratification. The other two are fantastic, and other people have addressed how we might do those, but just wanted to put a teaser out there. Okay, so EHR risk stratification. Many of the applications that actually use machine learning models for decision support manifest as risk stratification models. And I think there were some reasons articulated earlier this week about why decision support or treatment recommendation models might be problematic. But if we have some sort of risk stratification model that just says this patient's at risk of developing a complication or at higher risk for in-hospital mortality or something like that, then the providers can work together to just allocate care accordingly, or kind of just provide extra monitoring or something like this. Typically speaking, or at least in terms of the models that are live, these applications ingest hand-identified and crafted EHR features to make some sort of binary decision, at risk, not at risk, which might be implemented as a flag. So some examples of these, there's been a sepsis alert system developed in Johns Hopkins that's deployed. We have some models that predict complications and mortality following surgery, so identifying people in the perioperative setting who are at risk. So they might be targeted for continuous monitoring systems or something like this. You can also have other predictive models that maybe predict likelihood of positive COVID tests or in-hospital mortality among heart failure patients. And these models keep coming out. I have a saved PubMed search that gives me, one or two of these models that claim that reporting, here's a new model to identify deterioration in heart failure patients or something like this. I get one or two every morning or so. Okay, so to develop one of these models, we, as kind of more the modeling group here, we might be approached by a potential collaborator. Our expectation is that they might have, this very well-defined, target cohort of interest, target cohort and an outcome of interest that they want to model. Maybe we might have to work together to come up with what are the most, predictive features to predict this outcome of interest, and then we'll go through a few iterations developing and validating this model, and then we can deploy and everything's fantastic. In reality, all of these are iterative and kind of repetitive processes. I did say I was going to vent a little bit. Maybe I'll tone that down just in the interest of time. But just as an example, we engaged in a project to try to identify patients who might be at risk for an avoidable emergency department visit. And the idea is, if you show up at the emergency room with maybe a stubbed toe or something, it might have made more sense for you to go to, say, somewhere like urgent care. So we started off with just trying to classify, hey, can we tell, given patients that show up at the ER, is this visit avoidable or unavoidable? And we trained a classifier to do so. That was fantastic. And then it was made clear to us that when we showed this back to our clinicians, they said, this is great. There's one problem. We can't turn people away from the emergency room. So the problem has now completely shifted. We actually want to identify patients who are at risk for an avoidable emergency visit before they show up at the emergency room, which is a much harder problem. We had to change our cohort of interest. So we tried to do this. Had a slightly worse performing model, but we were able to say, okay, of all of the patients in our primary care system, here are the patients who might have an avoidable emergency room visits. After reviewing some of these cases, when we were considering deploying something like this, another piece of feedback from our clinician collaborators was that, okay, well, it's not clear that what you've considered avoidable for an emergency room visit is actually avoidable. So what we did was we just, you can come up with a pretty simple heuristic where if a patient went to the ER and they were sent home, maybe they didn't have to go to the ER. But what if they showed up the ER with chest pain or something like this and they ended up sent home? Not very clear whether that's not an avoidable ED visit. They should have gone to the emergency room. So we went through several rounds of this. And then we went through also all the growing pains with feature generation, extraction, all of these things to try to develop our model. This project started in 2019, and it's still ongoing, kind of pretty slowly right now. So with that, I'll end rant and kind of just say that each one of these risk stratification models is a specific solution, and this process requires iterating, repeating over data preprocessing, and all of the steps that I mentioned before. Now, in terms of defining the cohort and the problem at hand, that's kind of out of our hands. But if we can develop an approach that can kind of flexibly ingest data in the electronic health record, then we might be able to kind of speed up the model development process, at least, and iterate a little bit quicker. You might be able to adapt this representation to other tasks. We might call this a foundational model for electronic health records. So coming back to the electronic health record, the EHR measures signals across multiple biological and time scales, as we've kind of talked about throughout the week. These data are heterogeneous. They could be sparse. They're not missing at random. They're difficult to synergize and harmonize with each other. And prior to larger AI models, these were typically addressed on a per analysis basis. So I want to say a few words about kind of these language foundation models. I know James did a great introduction to these earlier in the week, so I won't say too much about them. But we would like to leverage, or at least they have some nice properties in that they're able to flexibly capture complex relationships between latent semantic concepts. We can claim that they exhibit strong comprehension and information extraction abilities. Maybe at this stage, we may or may not trust their reasoning capabilities, but the working hypothesis here is that their internal representations can be adapted for these types of risk stratification decisions. So the question that we're trying to answer here is how do we adapt these models for the electronic health record? So slight detour into how these things are trained. I know James gave a great introduction into this earlier this week, so I'll just say that for the most part, these models are trained using masked language modeling. Essentially, you're given a piece of text, and the model is optimized to try to predict either randomly or systematically masked sequences of words in this text, kind of like a Mad Lib. It turns out if you do this over sufficiently large corpora, then the resulting latent representations have these nice capabilities that we see. I know I listed BERT here, which now kind of seems like ancient history, but the intuitions for training these are similar. Okay, so why go through this? Well, a loose analogy can be made between electronic health records and language. I don't know if, oh, excellent. I think that's visible. But so typically our corpora, which we use to train these language models, are made up of maybe documents of text, which are composed of paragraphs, which are composed of sentences, and then ultimately words and maybe subwords, depending on what kind of model you're using. Now, a loose analogy can be made between that and the electronic health record. So you can think of a patient in the EMR as, say, a collection of encounters or touches with the healthcare system. Within each of these encounters, they may have had a number of things, let's just say diagnostic codes assigned during each of their visits. So you can, if we're just talking about the world of, say, diagnoses that a patient might receive, they might have had, they might have had nothing for a few visits, and then they had a few diagnoses for like pre-diabetes or high blood sugar or something like this. And then over time, you can see these diagnostic codes evolve. You can draw an analogy between these diagnostic codes and words, and then you can connect each of these collections of diagnostic codes that make up a single visit as, say, a sentence. That's what I just said. So just a little bit more concretely, you might be able to treat these sequences of data in the electronic health record as if it's just another language made up of these tokens of codes or tokens of discrete elements captured within the EHR, arranged over time, and train one of these new foundational models. So this has been done by quite a few groups. This is a nice review published about a year ago, and each of these columns represents a model trained roughly in this way. Now, it's been repeatedly shown that this improves predictive performance. There are certain limitations in that it's very difficult. So let's say a group has developed a foundational EHR model on their own data. It's not clear whether these data can be shared so that other people can use this and verify these models. Alternatively, so I've been talking about this approach where we train a brand new foundation model for these EHR. Alternatively, we can use widely available language models, for example, GPT or Llama or other models trained on natural text, and apply them to clinical text. So in addition to these structured fields that you get in an electronic health record, like diagnostic codes, laboratory values, the clinician also comes up with these pieces of text. These might be progress notes or discharge notes that kind of have curated, or I guess what the provider decided was important to include in these reports. This has also been done. You can take clinical notes, pass them directly into language models, whether they're tuned for clinical data or not. These are also able to perform quite well. Now, a limitation here is that these types of approaches need clinical text, which are notoriously hard to come by if any of you have tried to track down clinical text databases. So in the last few minutes, what I wanted to talk about here is whether we can develop an interface between these widely available large language models, which have these nice properties, have been trained on a huge amount of data, and these tabular EHR, which are generally speaking incompatible with these clinical language models in their raw form. So, just some attributes of each. Our tabular EHR may contain more granular information. We have quantitative measurements in there. Data are more readily available. Training these foundation models, even though it's been done, it's expensive, it's hard to share. These clinical language models have kind of all of the advantages of, say, your more general text-based models like your GPTs. Problems are that they're restricted to a text interface, and the data that you would feed into these models for risk stratification are notoriously difficult to access and share. But either way, whatever approach you take, the foundational model will be, both of these approaches can rapidly ingest electronic health record information and perform a variety of tasks, or can be fine-tuned to do a variety of tasks. So I just want to say a few words on clinical notes. I mentioned before that they kind of serialize information reflected in tabular data, plus some additional subjective judgments. A lot of these clinical notes within specific service lines, they follow a template. And a lot of these are generated using these smart phrases or dot phrases in Epic, depending on your EHR system. And what that is it's basically a pre-generated phrase that kind of a clinician might type a shortcut for, and it pre-populates that into your clinical text. So it's not actually written by the clinician, it's just pre-populated and programmatically generated. And so the question here is, can we develop an interface between tabular EHR data and these widely available LLMs? A lot of this work was performed by Simon, who's over there, so I will shamelessly send hard questions his way. I just wanted to show an example of one of these clinical note templates with dot phrases, and hopefully you can see this template on the left, but one interesting thing to note here is if you see kind of a field surrounded by @ symbols, this is a dot phrase, right? So this is pulling information from the chart into a pre-populated text template. If you see 3 asterisks, that's where a clinician might type in a sentence that they type in their own sentence in natural language. And the thing that kind of jumps out is that the vast majority of this clinical note is actually generated programmatically. there are questions about whether this is actually productive in the clinical environment. We're seeing that more and more dot phrases are being used. These clinical notes are getting longer and longer for this reason. But I think the jury's still out on whether they improve clinical practice or not. But kind of building upon this idea, we proposed these clinical pseudonotes, which is kind of making up our own dot phrases, essentially, to convert these tabular data into text. And what this does is it makes these clinical data compatible with large language models. So we can do something as simple as just taking our tabular data elements, converting them into complete sentences. The resulting text we can just feed directly into our LLM of choice. I'll gloss through. I'm running a little bit out of time, so I'll kind of gloss through the next few details. Another observation we made on the electronic health record data is that the EHR measures signals across multiple biological scales, and it may not make sense to represent all of these within the same space. It may make sense to say, separately represent molecular level measurements, say blood tests or something like this, from system level measurements like diagnostics or interventions like specific medications that were given. So in this case, we introduced the multiple embedding model for EHR, or MEME, which basically we generate pseudonotes for each type of electronic health record data and feed them into separate embedding models and then concatenate them. Okay, I need to go quickly. So we're going to come back to the emergency decision support scenario with our MEME approach. So I guess we'll just very quickly say that you don't want to. So we want to be able to triage people quickly in the emergency room. And we use this as our test case for whether our approach is actually able to flexibly represent these EHR data. We use the MIMIC data set to develop and validate this model with the following tasks: looking at whether a patient would be sent home versus further admitted into the hospital, so ED disposition. And then we also looked at decompensation, so if they were admitted, would they further decompensate throughout their stay. Results, so what you're looking at here, our approach are the bottom two here. So this is basically taking this idea of converting the electronic health records into pseudonotes and then passing it into a model that can embed text and then making these binary decisions, compared with these foundational EHR models. For example, can you see my mouse? Oh, that's not where my mouse is at all. But anyway, these three models in the middle here are foundational models for EHR using that other approach that I described earlier. And the jury's out on whether these approaches are truly better. We'll see. Here we're just showing that you can plug in a number of base models to embed your clinical text. And also, one question arises, especially with now like GPT-4 and as they keep improving, do we need to do this at all? It turns out, at least when we benchmarked this against GPT 3.5, that there was still value in doing this type of approach where we, do this fine-tuning on our own. Okay, let's get to some limitations. Sorry for blasting through the results, but I wanted to talk about this because it ties in nicely with what a lot of what else has been presented this week and today. One observation in this review paper that I cited earlier was that a lot of these models have been developed and tested on the same data, specifically the MIMIC data sets. And it turns out that we benchmarked our model on emergency department encounters at UCLA, which we call the institutional data set here. And we can already see that there are some differences in kind of the patient characteristics just by looking at the rates of these different outcomes. And you see that, we have some pretty stark differences in terms of within dataset performance and across dataset performance. And a number of you have presented these methods that we can use to kind of quantify these differences or maybe even overcome these challenges. I'll leave that, but we haven't made any attempts here. I did want to just kind of highlight this quote that that this review stated, that it's alarming that that a lot of these kind of clinical text models also were not validated on clinically relevant tasks, rather just on kind of general, clinical summarization problems, that type of thing. And on the right, I'm just showing a just count of distinct concepts represented within our institutional or within the UCLA data, and concepts represented inside mimics. And part of this is because that we're a large academic medical center here and just see a wider variety of patients and provide a wider variety of care. Someone's going to have to deal with this. So we'll end here with just kind of a brief summary that we introduced the pseudonodes approach to offer an interface between tabular EHR and LLMs, which is largely driven by this dot phrase functionality within Epic. But even if we are able to interface with these large language models, these future work should be looking at the transferability and portability of these. And I'll also caveat that a lot of model-based decision support has been limited to the inpatient setting. And so, for those of you that are looking for more computational challenges, moving into the outpatient space where missing data are rampant, healthy people don't show up in the healthcare system in the outpatient setting, this might be an interesting place for you to go. We're also looking at alternate readout methods. So what you're looking at here is just like a similarity matrix in this constructed out of the representational space of these LLM models. So maybe we can do some sort of nearest neighbor-based retrieval for decision supports. All right. Sorry that was so fast, but we'll wrap it up here. I think it's time for another coffee break, but I think we can take a few questions.